Good morning, John. I think you can get started if you like.
Good morning. Hi, everybody. Hi to my special guests. Welcome everybody to this webinar. Thank you very much for joining. Hopefully you're all sitting at home primarily, I suppose, because some of our transport is down today. So welcome you from wherever you are. My name's John Gannett, and I'm the general manager for Innovator in Europe, having joined the organization in January this year. By way of background, Innovator is a 10-year-old health technology company based in the USA and India, which supports the delivery of efficient and effective integrated care. And on a day-to-day basis, our applications and data platform support the care of over 40 million citizens across multiple accountable care, managed service organizations, and primary care networks, as well as public health and social care organizations in the USA. And the idea for this discussion actually came about from an educational trip that I attended with NHS and social care colleagues earlier this year, where we met with organizations like Banner, Kaiser Permanente and Dignity Health, as well as newcomers like One Medical, who've been in the news recently, and Mtiro, who are a managed service organization. And you know, the main reason for that educational trip was what colleagues set out to find was answers to the question of what does good look like, and what are the features of high-performing accountable care organizations that we could learn from. So based on what we found and what we discovered, we thought it would be a great idea to run a similar session with a set of colleagues drawn from the USA and the UK with international experience to explore this subject with a wider audience. So without further ado, I can take us through the agenda. And by the way, while we're going through this, if you push questions into Q&A, we'll assemble those and we'll talk to them either as we're going through questions to my learned guests, and we'll pull together some questions as well at the end for Q&A. And if we don't get to all of the questions throughout the session, then we'll come back to you over LinkedIn post the event. So let me just get our colleagues to introduce themselves. As I said, I'm John Gannett, General Manager for UK and Europe for Innovator. We've got Professor James Kingsland, Phil Scott, and Dr. Paul Grundy with us. So should we start with you, Phil, and then to Paul, and then to Professor Kingsland?
Good afternoon, everyone. I'm Phil Scott, as you can see. I've ex-CIO at Bolton, but many years working in the service across all the health domains, acute, community, primary care, and also some mental health work. Also done some work in social care, and really interested to get perspective from the audience in terms of some of the issues that we're facing and how we might address them through digital services and solutions. So good afternoon to everyone.
I'm Dr. Paul Grundy. I'm the Chief Transformation Officer at Innovator, and I'm a professor of family and preventive medicine at the University of Utah and professor of health policy at University of California, San Francisco, and author of a couple of books, including Provider-Led Population Health Management. I started a movement some years ago that became known as the primary care medical home movement in the United States, organization to drive that, and was asked to and really enjoyed working in the UK when they kicked off their first 15 pilots on primary care medical homes some years ago. So glad to be with you.
And last and least, James Kingsland. I've been working in and around the NHS for nearly 40 years now, 31 of which was in general practice, but recently stepped down from clinical practice, but still doing a lot of work in undergraduate teaching at the University of Central Lancashire, postgraduate research, currently running a national programme looking into health inequalities across England. But I think I'm here to hopefully give an international flavour. Whilst I've worked in all sectors of the NHS, I'm working as diverse from advising the government of the Isle of Man to being the primary care lead for the Faculty of Disaster Medicine in India and Nepal, and for the last 10 years been helping develop primary care services largely related to disaster medicine, and maybe even reporting on the most recent trip to Latvia just last week and Riga, where there was an international meeting looking at digital regulation. So some information on some of the work being done globally on best practice in digital care, and particularly how that supports more integration of services.
Great stuff. Thank you very much, folks. That's tremendously useful. I think we've got the agenda up. So really, we just thought it'd start. Not going to spend too much time on this, but talk about what we're seeing in terms of some of the challenges for the NHS and social care, and more broadly across the 4 countries of the United Kingdom. What are we seeing? What are we experiencing? And how does that sort of provide further impetus for this move toward integrated care and integrated care systems that we're seeing here and elsewhere? We'll then sort of get into the meat of the conversation around what is it around what we've learned from counter care organizations in the US and elsewhere that are worthwhile sharing, and into sort of from there into best practices, and then finally what do we think a connected care ecosystem should look like, after which we'll run back into Q&A and then a wrap up. So without further ado, let me stop sharing my screen, and let's get everybody up. There we go. Can we sort of just have a brief conversation around what are we seeing in terms of the well publicized challenges within health and care in the UK? What's our take on them? Phil, Professor James, does you want to start that element of the conversation?
Yeah, happy to, John. Challenges that we're facing right now. Well, we're seeing it acutely in the media on a regular basis at the moment. Now we're in winter pressures and coming out of the pandemic, but things for me as a digital lead within health, aspects around AD and ambulance waits, the step down in social care discharge capacity, recent notifications around coming from the centre around EPR deployments into trusts, the elective recovery issue that we face coming out of the pandemic, and how we're looking for greater cross-organisational working. We're now also looking to exploit one aspect. Personally, I believe the pandemic we benefited from was the use of digital and technologies to support our clinical colleagues and our wider patients and population. And from that, we're now seeing greater virtualization in areas such as consultations, virtual wards, etc. So I think for me, these are some of the real issues. We're also now got a new organisational model, ICBs, now at a regional level, now looking at commissioning and primary care management, as well as ICS providers being asked to look at working in a more cooperative relationship. And again, recent indications coming out from the centre about devolution of some strategic responsibilities down to a kind of regional and local level, away from NHS EDX. So I think that's some of the aspects, John, that I'm picking up from my perspective as a digital lead.
Fantastic. That's great. Thanks. Professor Kingsland, do you want
Yes,
to add to that from your perspective?
Yeah, not to add, because Philip's given us some of the wide challenges. So there's nothing new in some of the challenges. I think it was 30 years ago I first started hearing about the challenges of the aging population, the increasing demand on the system, which we continually talk about, and the financial strain of incorporating new technology, new work. So I sometimes reflect on, we talk about it so often, we start to admire the problem. And as we know now, those three things have just accelerated. I'd probably look on the challenge slightly differently, and particularly from some of the work I'm doing on health inequalities, is the allocative value challenge that we're going to have in the NHS. What I mean by that is that we allocate cash limited resources, highly cash limited resources, in ways through the contracts that we've got. And we are going to focus on, can we manage the cold elective backlog? Can you get in to see a general practitioner? Have we got enough of those? Can we get into A&E? But that's sometimes at the expense of some of the work where I was interested with a meeting with one of the sites that I'm working with on health inequalities, who are looking after an agenda of troubled families who have got children with complex mental health problems, who go to bed at night with their bellies empty. And one stage they were saying, I'm really sorry, we've not been able to manage any work in the last month because of business as usual, because we've got to get our vaccination program and better appointment systems, which is really important, but is at the expense of saying, so we've got to leave children with complex mental health problems aside for now, because there's no mechanism to look after them other than the project. So I think the allocative value is going to be a challenge. And when we talk about moving resources around sectors, particularly increasing the provision in a community setting to allow more proactive early detection, it does mean that we'll have sector change, because when we change care, we ultimately have got to have financial changes, and that leads to institutional changes. And I think that's going to be one of the big issues. The second is, within that cold financial climate, is how we utilize and deploy the resources to cut out the waste, duplication, and inefficiency. For example, the NHS wastes a significant amount of money on poorly executed and error-prone manual data management, which we're still doing. We still use paper records in hospitals. So there's a huge challenge, the digital challenge of improving utilization, because many who are working flat out will say, well, there's no spare, there's no wiggle room left. But I think if we have some time to reflect on how much duplication of work inefficiency we have, is a second. And the third, I would say, is that the biggest financial risk to the NHS is the morale of the staff. And I think some of the things that are happening now, this very, very unusual, I won't say unprecedented, I think we use unprecedented far too often these days, but the very, very unusual situation of nursing colleagues who are feeling undervalued, that they need to think about striking. I think it's more about the value in the system and the morale, which is often made better by improving professional esteem, work-life balance, reward, saying thank you, as well as the money. But we know money is an incentive. But I say that is probably the biggest financial risk, is the morale of the staff. And we're seeing, as we're going to, well, we have winter pressures for the whole 12 months of the year. As we're going into that, we're seeing that is probably how we create an environment in which people can work under these intense pressures without feeling so undervalued that they're thinking about striking, as we see with the ambulance crews as well.
James, when I was in England, well, I guess 5 or 6 years ago, I was in a clinic in Plymouth, and I was asked to be on a BBC morning show, and it was the height of the winter. And the question I got first was, how do we strengthen emergency room? How do we address the overcrowding in the emergency room? And my response to that interview is, you're asking the wrong question. The right question is, how do we strengthen primary care and the community resources around primary care to keep people from being in the emergency room? And when you look around the world at some of the exciting things that are happening, for example, in the island of Jersey, The postman who goes to every house every day stops and does a call and check on the frail elderly, does a call and check on those people just discharged from the hospital. And when I was asking this particular clinic in Plymouth, how many of your elderly are there because they're lonely? A full third of that population who show up in this particular clinic are there because they want somebody to talk to. They're lonely. And so, I mean, if you think about taking those community services that you in the UK have done so much better around than we have in the United States, and really integrating them and wrapping them around those primary care clinics in a way that supports the population better, I think, you would see many less folks showing up in the emergency room. The other thing is that it just broke my heart when I was seeing the folks that was running that clinic that were there until 10 o'clock on Friday evening, manually handling the population health data that they were being requested to handle by the system. That should all be automated, right? That technology is there to do all that for the person and resolve the time. I mean, the only two things that a primary care physician should do is difficult diagnostic dilemmas and relationships. Everything else should be run by technology or by somebody else. A behavioralist does a much better job in those issues, a clinical pharmacist and medication management, et cetera. So, I mean, I think the work that you've been doing with the Primary Care Association and strengthening integrated team-based primary care and making them the system integrator for managing a population will take us a long ways.
That's fantastic. So, Dr. Grundy, just to keep you talking, if you don't mind, can you sort of now segue into? I think that's a great starting point. Can you segue into what you've learned, what we've learned from from working with accountable care organisations as they've formed over time in the US, and what does a good accountable care organization model look like in the US in terms of outcomes, efficiency, effectiveness, and also the way it's staffed and staff morale, and just picking up on some of those points that Dr. Kingsland, Professor Kingsland brought to the fore as well.
I think historically the United States has done the best job of any place in the world at unaccountable care. We've created what I refer to as a milking machine in terms of paying for an episode of care, whether or not that episode of care is necessary, and moving away from that. I mean, the three key points I think that I've learned in my work is there's the three legs of the stool. It's the cultural shift and the training and education around managing a population team-based with data. The second is the payment change. There's only one way to hurt a cat, and that's to move the food. If you pay for the wrong thing, you're going to get the wrong thing. And even in the NHS, which has a beverage model, payment where a button to bed in theory should be a cost to the system and not a profit, payment isn't aligned. But it certainly wasn't the United States. And the third is, if you don't have the data at the point of care and easily accessible, to that system integrator to organize primary care in a relationship of care, you're going to have a system that fails. And I mean, I have been for the last 10 years a healthcare ambassador for the nation of Denmark. And we've moved 94.7% of all care to the primary care level. We have a philosophy that the last place in the world you'd want to place a frail elderly person is in a hospital. It's dangerous. Do everything at home, do it in primary care, manage it remotely, and really manage the medication that you have, in a positive way. But from the perspective of the United States, it's been a very difficult journey for us to move culturally away from a button to bed as a profit for us. But places like Kaiser have been doing it for years. The Veterans Administration have been doing it for years. So we're trying to move in that direction. So the payment change is that you're paid to keep a person out of the hospital rather than in the hospital. And so what we've learned from that is that it really takes an understanding of what's happening at the community level. It takes an understanding of where you have pockets of poverty, where you have people running out of food, where you have transportation issues. It's a real understanding of how best to take whatever community resources you have and wrap it around that patient, like the example in Jersey where they use the postman, right? I mean, but there are good examples of and I think particularly around how you get at with a modern AI platform, an understanding of what's happening across that spectrum and make it actionable at the point of care for the clinician, and so you know what's happening to those patients in front of you, and more importantly, you know what's happening to those patients that are not in front of you that day.
That's really helpful. So so you talked about some of the experience in terms of some of the emphasis on moving payment systems to change behavior. I think and you've also mentioned some technology there, as well as morale and staffing and education. I think, James, you travel widely, as you said. You just come back from being abroad. Would you like to sort of add in anything from your perspective to what Paul was saying?
Yes, because I often debated this with Paul over the years about the difference between accountable care organisation and accountable care.
Yeah,
I think the principles of accountable care are largely accepted internationally. I think when we say accountable care organisations, with great respect coming from the US, we have some antibodies, because the first thought is this the privatisation of the NHS, as opposed to the principles of accountable care, which is saying, can we get better outcomes within a cash limited budget? Can we do it, as Paul was saying, that is largely community based and focused on prevention, and for a clearly defined population where we understand through population health analytics their need, and then build in team-based care, as Paul was saying, which might ultimately include the postman, but at least a team that is built based on the need of the population being served. And now we know that is not, particularly in primary care, which we sometimes use the term general practice, which is of course only a part of it, but we usually refer to general practice plus, as opposed to proper team-based care, building a service which includes the primary care physician. And I agree entirely with Paul. During my time in general practice, I've gone full circle. Whilst recognizing the needs of the registered population, I trained as a doctor. I have a particular range of skills, diagnostics, treatment plans, but there's so many other people who do a much better service for people who present to general practice, and that's the first port of call because of list-based practice. But the building, as we're talking with integrated care systems, the building of the social care needs based on the wider determinants of health, the things that people present with, but they're better dealt with by a counsellor, a social carer, a physiotherapist. We have physio first sort of services, but can we build that into a fully integrated one team, which accountable care organisations espouse, that you have a one team approach to holistically manage the needs of that population. So I think accountable care principles, as I travel the world, nobody pushes back about moving more service into community, making sure we're dealing with the wider determinants and looking after the total need rather than a specific need. And that can only be delivered by team-based care, but the team needs to have a deep understanding of the needs of the registered population, whether it's registered or just an identified group of people who are within an organisation. So I think those two things that I see, but I think the principles of what was first described as accountable care are widely accepted. The organisational bit is another discussion we're still struggling with primary care networks. Do they ultimately could become an organisation rather than a loose association between general practices with a few add-ons, well, a few, the extended role systems. But as I say, that was just a reflection on what Paul was saying about accountable care.
That's incredibly useful. And I think, so Phil, I mean, you've got lots of experience of working in, ICSs from a technology perspective, as well as in the acute sector. What's your take on what we've heard so far?
It's interesting. I think the recognition is James and Paul have just informed us in terms of ACOs of the role that primary care. But some of the things that I recognise from recent working with colleagues in primary care is the situation with the workforce. You know, we've got an ageing workforce, and there's a recognition within the next 5 years about the further decline in that clinical workforce. So we now see, what I've certainly seen over the last 5 years when working with colleagues in that sector, is some wider roles in primary care. So, for instance, paramedics being more involved. It's a bit of asset stripping of the ambulance service to some extent, but we see paramedics being employed as part of the clinical workforce within primary care. There was something interesting just this morning I picked up on about social workers taking a more active and wider health remit role. Is also, I think, would be interesting to get a view from Paul and James from their experiences globally on that. From a digital perspective, I'm slightly anxious in the context of ICBs now have got that devolved delegated responsibility for strategy for primary care. So in one sense, it may look productive in that we may get some standardization across primary care within an ICB region. But the current economic situation of the UK economy will put some real pressures in terms of investment funding that will be made available into areas such as primary care, and more importantly, the strategic desire to have a greater integration of care, health and care services, both at a regional and at a local level. So I think that's some of my my views in that respect. So.
Okay, so I think so Paul, you mentioned the sort of drop down a level, if we can. What are some of the best practices we're seeing elsewhere? And I think, Paul, just thinking about the educational visit we had, one of the things that I think we all noticed, NHS and social care colleagues noticed in talking to people like, when we're talking to people like Banner and Entero, who are managing, doing really effective care coordination. One of the things we noticed was very much that was the result of having an effective care coordination function. And I think when we ran the numbers based on all of our experience of supporting organizations in the USA, we came to the conclusion that you needed about 80 folks within care coordination to manage a population of about 1 million. So, the sort of sweet spot for our ICSs over here, and those folks were, as James was talking about earlier, included, pharmacists, prescribers, social workers, case managers, clinicians, primary care, community healthcare, mental health care individuals who were able not just to manage transitions of care, saying, doing what we do well in the NHS to some extent, around bed management when people are in beds and we want to move them out into the community or step them down, but actually taking a broader view of an individual. And certainly what I'd seen is that we, with those 80 individuals doing effective care management, care coordination, we were able to touch 25%, or in the US, you were able to, handhold, touch, support effectively individuals in about, 25%, personal touch, personal support of that population with those 80 individuals over the span of a year. So, but clearly all of that requires, technology, thinking about data and integrating data and bringing together a really, really solid view of an individual. Can you kind of, you clearly have much more experience with that, Dr. Grundy, than I do from your experience of working with us over the last number of years. Can you kind of just provide a bit more color on some of those aspects, if you don't mind?
Happy to. I would like to take us for a minute with that third leg, with the leg of the stool for payment change. So in Denmark, we began to figure out that if we paid the providers in the right direction, we'd get the right level of services. So a third of a primary care physician is how well they service their patients. For example, if they have same-day appointments available and somebody wants a same-day appointment and they see the patient on that day, they're going to make 3 times as much money as if they see the patient 2 weeks later. If they have an email request and they answer that email in 20 minutes, they're going to get much more money than if they answer it in 24 hours. If they have adequate parking. But what is it that the patients want, and how do they service it, and how do you align that payment around that? I think is immensely important. And I think one of the things that we looked at was we took Kaiser Permanente to Denmark to study what the Danes had done. And then we put that in the system. So it's set up and it requires the technology to allow you to do all that stuff, right? That's immensely important. And that we spent a tremendous amount of time, really building, and we built it out of the doctor's office. We sat there and did the coding in their offices to make it effective for the primary care providers. But I mean, the value of that is immensely important, because on average, the response time for getting access, if you provide 24-hour coverage, you get 50 pounds a call for those calls after hours. So the team will take those calls because it's a significant part of their income. If you want to be on, go out on a date with your spouse that night, you just turn off your phone. And any GP in Denmark can answer that call, and the average response time is 2 minutes. I mean, talk about taking things out of the emergency room. It's just phenomenal. But organizing it so that the service level for the consumer is what the consumer wants. So what happens is that anybody who answers that call who's not the primary care provider says, I'm answering on behalf of your primary care Dr. Hans. He cares about you. He wants you to be serviced. And so when I was in Nottingham, I was asked the question, how do we integrate the relationship with the primary care provider to our walk-in schedule? And I said, it's real easy. Whoever interacts with the patient in the name of the healer that person has. I'm here today, I'll take care of you, but I will make sure that, Dr. Jones knows exactly what's going on and will care for you, and he'll follow up with you. So I mean, I think that's the foundation of accountable care, is really strengthening that relationship between the healer and the provider, and paying for that instead of paying for other things. On top of that, you really need to be able to have a pretty robust system of data to be able to understand and manage that and pay for it that way, right? It took us quite a bit of work to do that in the Danish context. And I think James, the Estonia is also looking at that similar system of care in terms of the data management.
And I think, as we pass over to James, I think we've got a couple of questions that are, how does the panel propose that we tackle inertial and historic culture within healthcare systems which resist change? And I think you can both talk to that, and I think to some extent you're touching on that. And how do we speed? What have we learned in terms of enabling this whole integrated care to be sped up, the adoption of it to be sped up? So as you're going through, if we can think about those in your responses, that would be tremendously useful as well.
Thanks. Yeah, it's good to see Joe on the call. Paul was talking about Call and Check from Jersey. I think it must be Joe from Call and Check who's put the first question. And the second one, really interesting question about cultural change to promote integration. I may touch on that because Paul's touched on payment mechanisms to improve access and response time. It was interesting that for those who were around in '97 when Tony Blair said as he came into government, we've got 24 hours to save the NHS, and the public's top concern was waiting and access. And Paul has said about payment mechanisms to improve response time. But below waiting and access, one of the really challenging issues around what the public's need is the continuum of care, or the continuity of care, which people are finding is more and more fragmented as we start to build bigger services. And what they mean by continuity. Just to link in what I'm going to say back to the question as well, is that aspects of cultural change, I think the biggest challenge, I think I'm up to 67 different definitions of integrated care. The best one I've heard is when we get to the integration of behaviours, and there's a big issue on that. The second is the integration of data. And I think the continuum of care which people want started to change, certainly in the UK with list-based practice in the 1960s when we had a group practice allowance. So as soon as you started to have GPs working together, you couldn't have the same GP all the time. And since then, well, I think what patients want is that not to have to tell their story multiple times. So what I saw Paul was mentioning is in Estonia was an interesting way of managing the continuum and getting that integration of data, because they're now one of the most interesting developments. Another one I'll mention in Singapore is that they're saying 100% of all of the population, they are on a digital record now. And I saw a bit of it in Estonia. And even they've talked about, well, the first question is, well, what about the digital excluded, those who can't go on a laptop or access an e-health record? They have a process by which you can nominate other people to act on your behalf, but they have got a nationwide system which integrates data from all providers. And in Estonia, like in the UK, providers are often using different software systems, different data management, but they create a common record, a digital platform that every patient can access online, or their nominated person, but they're saying they've got that 100%. And it's interesting that that central national database now, which can retrieve data from all these disparate systems, presents it in a standard format, which patients access and can add to, has really improved the continuity and the continuum of care, which is, as I was saying, is a really important part of our system. So I think if we get that right, we may get past the, I want to see the same person every time, to whoever I'm seeing must have all the information about me. So I'm not having to tell my story in an outpatient department, in the general practice, in the pharmacy, lots of different times. And they've got lots of, I won't go into the detail about ensuring integrity in those systems. And Singapore similarly have got a national electronic health record, the NEHR that they're talking about. And that covers public and private sector because they've got a large private provision. But their mantra is one patient, one health record, rather than just one healer. And that, again, is a summary health record that they have this login into a health hub. But they're really interesting developments, which is starting to solve the issue that is really challenging some of the NHS issues around the continuity or the continuum of information, which I think in itself helps with access, because you're not having to duplicate services or duplicate time. To come back to question 2, though, what the existing health and care culture in the UK, I think the questioner obviously knows how difficult it is to answer that. It's a real googly, because we from the start of even issues around a healthcare system which is free at the point of need, not based on your ability to pay, and a social care system which is means tested, which is the discussion: do we move the social care system into a free at the point of need? We know that's not affordable. Therefore, here's a googly: do you move health into a means tested system so that those who are disadvantaged the most can get access? But starting to build team-based care, and going back to when we were talking about ACOs interesting. One of the lines that Paul can correct me on this, but the ACO development is voluntary rather than herding the unwilling. I think Paul's cat's analogy, seeing a purpose in working together, recognizing that team-based care has a lot of science behind it, and building that in might start to build the culture when it is not forced contractually, but built from. And I think we've got the structures, primary care networks, as they mature and start to collectively look after the total need in a community. You start to realise that it can't be delivered by general practice as is, or pharmacy alone, or it's got to be a connection between the 4 contractor services, which is the primary care level in the NHS, along with community services, council services, wider social care, third sector. And then there's a purpose of coming together, because once you work as a team, you cut out that duplication, the waste. You can start to have a continuum through a care record. And I think we can learn from places, say Estonia and Singapore were the 2 that I saw had the most sophisticated development in a national coverage of a care record that patients had some ownership of, which we're aspiring to. And that starts to build in some of the efficiencies we were talking about as one of the challenges a huge challenge we have in the NHS. I better take a breath there at that point, John. Otherwise, I get into my Garrus mode.
No.
James, going back to the data, I mean, I think that we're in a generation, although we're both approaching the end of that, but we're in a generation where data and information is going to do for our minds, in our ability to manage our population, what X-ray and imaging has done for our vision in our career, right? I mean, when I started medical school, an ultrasound was a scratchy bunch of lines, and now it's anatomy, right? It's just clear what's going on. And I think that's what's going to happen with integrating data from disparate sources and making that data, with a bit of AI cleaned up, processed, and managed, and in your hands at the point of care, is going to save you 2 or 3 minutes per patient in knowing exactly what's going on, having an idea of whether they're short of food, having an idea, et cetera. I mean, but pulling all that data together and putting it right there, in front of you, is just going to transform how care is delivered. And frankly, I think that's probably, of the 3 things, the easiest thing to do. I think the most difficult is that question that was raised about cultural change. I mean, that's the most difficult, is getting the patients and the providers and the system to really begin to understand the culture of moving to that model of care.
And so, Phil, do you just what come your comments on what we've heard so far?
I think we've, in terms of the shared care record model, some 10 years ago, nationally, we looked to establish that in terms of some of the care record. But now we've all went in our own disparate regional ways into establishing a more complete care record. GMCR in Greater Manchester, the Yorkshire and Humber care record, Kent, are perfect examples of that. Where I think we are missing is some of that aspects of the care sector, which have now come under the umbrella through the 2022 Health and Care Act, that we've now got social care under the umbrella of health now. And I think that will give us an opportunity to realise aspects that Paul has informed us of in terms of that data acquisition of the social care side and the third sector side. So I think there's opportunities there. We've established really good pillars at a national level in things like the EPS, the patient demographic service. We have them well established and operating now. We've got the integration capability, the interop between systems working, the standards well defined technically and functionally, the data set. So we have a lot of that opportunity there at the moment. It's whether we continue that fragmented regional approach in terms of that consolidated health and care record, or do we try and aggregate again to something at a national level? I think that would be a comment I would pick up on at this juncture, John. And probably the apps, the development of the apps in areas for social care in areas such as housing and the third sector area as well.
And I'd just be interested in from what you've seen from some of the stuff we've done in the US, where we have lots of interoperability within organizations. We a lot of the providers have very digitally mature EPRs, which we're now beginning to look at how we deploy in England. But nonetheless, they very much support an acute or tertiary sector activity. From what you've seen in terms of how organizations in the US are then overlaying that, creating a single best record from their integrated set of data, and then using that to support care coordination, care management. What's your perspective on that? Is that something that's required here, or do you think we've kind of answered a lot of those questions already?
I mean, we've always had the argument that in each of the health sectors, we had our silos of our respective data repositories: primary care, acute, mental health, community. As through ICS cooperation and collaboration, I would see that there's a greater opportunity to establish better EPR integration or standardization in an EPR within a particular merged group of trusts. At the moment, in primary care, and James will know this well, by and large, we've had a monopoly of two suppliers in England in terms of the primary care space. We've now just opened up the TIF framework, and we now have two greater competition in primary care digital systems as the principal primary care system. So I see that, along with the technical standards and the integration capabilities and the data definitions that are now well defined in the service, we've got opportunities to create that consolidated record. Where I think we, in my experience of working across certainly the health domains, as I call them, is that each of these respective EPRs, whether it's in primary care, acute, mental health, or community, we've not had that workflow. And James and Paul mentioned it explicitly around the ACOs, is that we've not had that capability through that care team model of working that ICSs are vested upon. We've not got that technology that allows that workflow across the clinical pathways. And I'd be interested in Paul and James's view in that respect.
James, I'll defer to you, but you're on mute.
Oh yeah, so sorry. Going around that, I'm just conscious of the questions as well, and there's two I'd love to be let off the leash on, if I may.
Which two are they, James?
There's the question about what needs to be done for primary care networks to be a success. Some examples of not working well, and just going back on the health and equalities issue. I know it doesn't necessarily link directly to the title of our, but if I may, I'll try and be succinct with it. But I could be let off the leash on the first, because whether
why don't you go for both, and then there's another question here.
Okay, basically that Paul knows, because he was involved in the early stages, that I was one of the creators of what we call the primary care home in 2015, and the success of that development led to NHS England adopting some of the work into primary care networks. So the first thing about what needs to be done is a clear understanding of the purpose, the construct, and the principles of what was being designed in that example of primary care at scale. The first thing is primary care at scale can be done lots of different ways. And the primary care home, which was the first to describe the 30 to 50,000 population size, I am the person, and I've got the unpublished paper that first described why the 30 to 50,000 would be a good starting point, not finishing point. The point at which you would build in the principles of the primary care home, team-based care, the multi-professional team that could look after those size of populations and start to manage a budget on behalf of that population. And we're nowhere near that with primary care networks at the moment. The other thing with the primary care home development, it rapidly spread to cover almost 20% of the population of England within a very early stage. But when I was going out to talk about primary care home development, colleagues who were saying to me, interesting, James, we're doing it differently and it's working. And my answer was, if you can prove it's working, do not change. And these were GP federations, organizations working at lot larger sizes or smaller sizes. What has damaged to a point is those who were doing really good jobs at different sizes have been disenfranchised now by being told contractually they must be in a primary care network. It's history, but if we want to look at the real reasons why some networks are working and some aren't, some get it because it was the right model for them, others had a different model and were working and being told to change. But to really make primary care networks work in the future, they're fairly immature. In the main, they are aggregates of general practice in a loose association. But the primary care home espoused that ultimately over time, you would think about some organizational form, get the function right first. You would have team-based care. And if you were having approximately 200 people, I think there's a question earlier about the numbers of people looking after a population. The reason for 50,000 was about 200 health and care professionals supported by management could look after a population's demand on the service based on the research I did in 2015. So the demand was based on 2015 statistics. That's changed, but 200 people could look after 50,000, 100 people, whole-time equivalents, and the cognitive level at which people can interact both professionally and socially. As soon as you get more than 200, you start to have dysfunctional teams, and that can be very dangerous. So between 100 and 200 people could look after between 30 and 50,000 by demand on the system in 2015. So as it's changed, sorry, John.
Yeah. So I think that question was around what I was talking about in terms. So that's really useful, and it actually helps me answer the question. So I think the question was from Melissa around the 80 people I was talking about. I think the 80 people I was referring to was that care coordination function that we've seen put in place in the USA, that acts across the system, that takes the population health analytics and identifies the cohorts and provides that sort of top level. I think what you're describing is then all of the other folks that are needed to effectively provide the day-to-day care. What I was talking about was the care coordination function, not all the entire population that's required to support those primary care networks, as you just described.
So the bottom line was the primary care home
answered your question.
Took some design faults out of what we'd seen previously about aggregating to become a scaled primary care service. So the principles are relevant, were well researched, not necessarily adopted. And I think that's why some primary care networks are struggling, because they have no raison d'etre, or they were doing different things. The interesting thing about primary care networks was, as you may have started at a large size to be able to do proper population health analytics, particularly to build in whole time equivalent personnel into a team, but also risk manage the budget, albeit indicative. But if you don't reconnect the budgetary responsibility with the people who are deploying it, you have difficulties. But over time, as you get more sophisticated at doing the data analytics and managing budgets, primary care networks should get smaller. All of the debate at the moment is how do we scale them bigger to really get granular and deliver what patients want: good access, continuum of care, local services, knowing their healers. Is that you would start large and get smaller in the network as the microsystem in our new architecture. Just on maybe a line, because I know we're out of time, on the health inequalities, the Complete Care Community Programme that I've created and running, if the colleague wants to look on Arden and Gem CSU website, look for Complete Care Community Programme. Sadly, the acronym is CCCP, which is a bit unfortunate at the moment. But the Arden and Gem CSU or HealthWorks UK have got more information about what's happening. The first evaluation of the early design, but there's no, what we're finding is, as I was saying earlier about allocative value, NHS contracts direct us away from looking at these most complex areas of mental health. They're done as a added extra. But what we are doing is building a program and evaluating it. It's becoming a research network. But if you want to look on those websites, you'll get a lot more information.
So I just
James,
so
there's a
thanks for that,
question
James. I think
about the
Paul,
equity that I wanted to quickly address and
yeah, I
examples
think
of
so,
it.
because it's a great
So-
question. Rather than the current focus on NHS health checks, vaccination targets around food insecurity, complex mental health,
Yeah,
and vulnerable
if I
families,
could
which I
answer
know
that,
we've got a lot of experience in. So I think
if I could
that's
answer
a
that.
great, perfect.
I was sitting in Nottingham, and they had a weekly huddle of their primary care home. They had the folks that were responsible for housing, for fuel, for food, for the visiting nurse, etc. And they would sit there and they would go over their more complicated cases and pull it all together. Now, my thought was, if we could do that with data, if those folks were doing what they did and that information was made available to everybody interacting with that patient, you would have a marvelous system of care. And I think that's what we need to work towards, really, is taking the amazing work that happens across the spectrum, including the idea of the postman visiting, but taking the services that are available and documenting that with data and making that data flow and becoming actionable information at the point of care to that person who does not any longer have to spend the entire Friday evening, with a spreadsheet, getting at that information. That is, I think, where the few really successful accountable care organizations have done in the United States. And I can think of great examples of that, where we've really impacted hospitalization for our type 2 diabetics because they're running out of food, right? But by making sure they have adequate food. But digitizing and making available with the modern data platforms that exist, what should be happening with those huddles that I saw in Nottingham.
Great stuff. Sorry, I was just typing an answer to one of the questions. Fantastic. So that's really good. I think we're heading towards the end of the hour. We could probably run on for a few more minutes, but I think if we, I think that's been tremendously useful from my perspective. We've learned that there's been a journey in the US and elsewhere around bringing everything together around citizen, patient, individual. I think Dr. Grundy, you talked a lot about, and Professor Kingsland, you also talked very eloquently about sorting out the allocative value, which is one of the things I've observed as well. But assuming the experience in the US in terms of changing some of those funding models then drives different behavior, it's all a question of what are the conditions we put in place to be successful around doing effective integrated care or accountable care. And I think one of the things that's come up is we've got some, from a technology standpoint, we've had a lot of work around shared care records within what are now most of the ICSs, although not all. Although, even that from our experience very much, I think from what I heard, very much provides a raw level of data. And when we talk about doing effective care coordination, care management, you really need to harmonize that data and produce the best single record around an individual that then enables you to really effectively, wherever you are, whether it's in a food bank or in housing or education or in mental health care or community services, as well as in the acute and primary care space, you need that really rich and effective, accurate record around an individual to care for them effectively. And so I think we've learned a lot about that. You talked, James, about experiments and experience from Singapore and Estonia, which very much is driving towards, if I can accumulate a couple of things that you said, one patient, one record, and one healer. So that's a combination, I think, of what James and Paul were saying. So which and clearly, technology enables that more effectively. I think, James, as well, your points around primary care networks and what is the unit of organization that is required to effectively look after the population. I think there's there's a lot more work to be done here and a lot more learnings from initiatives that you've got in place, like the complete care community program that I'm familiar with. I think, Phil, you know, great observations around your experience from, you know, from some good technology that is in place, and I think your take on that care coordination, care management, which is sort of the, you know, missing from what we see in the US compared to what we see here. Anything more before we kind of, I think we're just slightly over time. Anything
Yeah,
more
I have
from colleagues
one quick
as
comment.
I wrap up?
There was a question that was asked that was exactly the same question that Jeremy Hunt asked me when I went over to begin supporting them on their primary care medical home, and that is, how do we change the system? How do we educate training of our teams? And you know, again, I said, I think that's the wrong question. I think the right question is, how do you identify early adapters, supporting them? Because the most difficult of those three legs of the stool is the cultural change. It's the training. The technology and the payment change is much easier. But if you identify, you know, those folks who are making progress, and there's lots of them, and make it the physicians that are driving that, or the clinics that are driving it, you know, support them with the training and education. That's called a tipping point method of movement, where you know, you give them the data, you give them the information, you know, and the practice down the street is going to see that, and they're going to want to, and they're going to, then you proceed to the early followers, and you fire the laggards, right? I mean, you know, that's what you do. It's called a tipping point, and it's a whole lot easier to identify, as we did early on, 15 practices that are already early adapters, and supporting them, and then Professor James said, and then pretty soon there were 20% that were practicing that way. I mean, that's I think the way to drive change in England.
Wonderful. Thank you very much. I think we probably have run out of time, so we've got to leave that there. We'll go back through the questions and make sure we've answered them, and if we haven't, or we can add in any information in, we'll provide answers back via LinkedIn, I think, if that's okay. But in the meantime, thank you very much, Dr. Grundy, Professor Kingsland, and Phil. That was a great conversation. I thoroughly enjoyed it, and I learned a lot, and I'm hoping our audience members did as well. Thank you very much indeed. I think, Himanshu, it's a wrap, if you don't mind.